Good afternoon, everyone. Today is January 28th, Friday. This is our weekly event for Delaware Health and Community Updates. This is United Medical ACO. My name is Kemal Erkan. I'm here with Sean Donegan. Sean, how are you doing?
Doing well today. It seems like January actually flew by. Already in January.
Almost done. All right, so we are going to start our session. Today is our clinical, this week is our clinical week, other than our regular topics. So I am going to start. We'll discuss hypertension with Dr. Barnett-Smith from United Medical Clinic. But before that, Sean's cartoons. A lot of confusion with the COVID updates, I guess. So this kind of does justice.
Yep. So this one here, I think a lot of people are thinking just because the numbers of the cases are going down. We saw that spike happen and we're starting to go down. So a lot of people are under the assumption, that it's kind of coming to an end with the new variants and whatnot. But
never ending.
No, as we know, is not over. So of course, same precautions and kind of protocol is definitely still being followed across our state, and hopefully the nation has some of the same approaches that we're taking here.
All right, so we have the cases updates and the vaccine updates, if we can go through those very quickly.
Yeah, sure. So as I just mentioned, the cases are going down. So compared to last week, it was at 752,000 for the United States. As we see here, we're down in the low 600s. It looks like 613. So that spike kind of did reach its peak and is now on its way down, kind of like what we expected since the holiday rush with our winter. Now, like I said, January is almost over. So I'm ready for spring at least, but we're getting close to spring. So. And then here's just a visual. You see that red line is going to be our trend with the numbers. It's a little bit easier to see the spike actually turning downwards now, which is obviously a good thing. But as you see, there are those blue lines representing the outliers of days where we had enormous reporting of cases, but overall it is starting to decrease. And then in regards to vaccinations, we have a increase, 7 million more from last week in the United States. So we are up to 537 million doses so far, and it's about just under 82% of the population to be accounted for with those doses being administered. And again, below we have the visual of a steady uptrend, which we've seen the past few weeks and months for the United States, slowly increasing over time. And then just a comparison here with the fully vaccinated rates, we have the US is kind of included inside of that green box there with a total percentage of 63.5% US citizens being fully vaccinated. And when you compare that to the state of Delaware, we are just below that at 61%. And then we do have the same percent comparisons for each of the age category brackets there. So for people over the age of 12, the entire nation is at 72.3. Delaware is just under that, 68.8. And then over the age of 18 years, we have 73.9 for the entire country. Delaware, again, just below at 70%. And then the age group over 65, the entire nation is at 88.2. And Delaware is actually beating that at 92.6. And then just on the left-hand side, we do have the total numbers of people being fully vaccinated. So we're over 210 million now. And then those receiving booster, over 85 million.
So did you get your free vaccine?
I did. I had, and we also have our masks here, the N95 masks being distributed. I know they also had the COVID tests that we had mentioned a few weeks ago that were being sent out to homes. I think it was 4 were being sent to addresses, and now obviously the masks are being distributed. So people should definitely take advantage and get the N95, as we know that's the most effective at preventing the spread.
What I really meant, did you get the test kit, at home test kit? But
oh no, I personally did not. For us here, I think my mom said back home that she did for our family, but me personally here, no.
All right. Thank you for the updates, and I believe February is going to be still kind of problematic with the total number of cases, and we still see the numbers being numbers still going to be high with the winter. But today, our clinical discussion, we have Dr. Rhoneise Barnett-Smith from United Medical Clinic. She's going to join me with Donna Gunkel, our Director of Clinical Integration. So, Dr. Barnett-Smith, thank you for taking time. I know today is your day off.
Yes.
And what's better to do, right, on your day?
Absolutely. Can't figure out a better way to spend it than with you.
I was just telling you, Sean, that, Dr. Barnett-Smith is so much fun when she joins us. So, and I really do mean that, by the way.
She's in high demand. We try to get her for our diabetes program as well. So,
well, she's I really do enjoy our sessions, and thank you for joining us. So we this year we try to make this a little bit different. Just pick the topic and then just have the discussion at the primary care level. And we are also sharing some of these videos, just taking this section of the video and then share with our patients. And that's kind of like our goal is to educate our patient. And as you know, we started daily case conferences other than regular case reviews that we have. And this is part of that when we do it on a daily basis and when we go through different patients on a daily basis, certain problems, certain diagnoses come up very frequently. Well, actually, hypertension is probably by far is the number one. And when we were looking for someone to explain us what hypertension is and how we can actually better understand what it is and what we need to do, that's where we ask you, and here we are. And I'll try my best to follow you with your presentation. You can always yell at me if
Never. Okay, well, thank you so much for that wonderful introduction, Kemal. I am Dr. Barnett-Smith. I am with United Medical Clinic. I work in Bear, Delaware, and I am very happy to speak with you for a few minutes today about hypertension, because as Kemal said, it is something that's very prevalent and we see it all the time. And the more education we get out there, I think it's going to be the better for our population in general. So let's get right into it. Next slide. When people say hypertension, what do they mean? What exactly is that? So hypertension, which you also may hear as high blood pressure, simply put is when your blood pressure is higher than normal. And blood pressure is the amount of pressure that the blood gives when it's pushing against the walls of your arteries. And looking at what an artery is, it's a blood vessel that carries blood from your heart to the other parts of your body. So you can imagine that having a lot of pressure against those arteries is not a great thing. Blood pressure normally will rise and fall throughout the day. So someone can have a higher blood pressure in the morning, and then when they get home after work, their blood pressure is a lot less, and that can vary throughout the day, and that's normal. But if you have an elevated blood pressure for a sustained amount of time, that can cause damage to your heart. And it can also cause health problems if it's not treated. Uncontrolled high blood pressure. So that's blood pressure. Can you go back? Yes, there you go. Uncontrolled blood pressure also puts you at higher risk for diseases that we hear about all the time, like stroke, heart disease, heart attack, kidney failure. those can be compounded or made worse or put people at risk if they have high blood pressure. Now, next slide. One of the questions that I get asked most often when it comes to looking at blood pressure is, what are the symptoms of having high blood pressure? And unfortunately, for most people, at least in the beginning, they don't have any symptoms. And it's for that reason that high blood pressure is sometimes called the silent killer. It also is a very important fact to illustrate why you need to see a doctor on a regular basis so that you can have your blood pressure checked, because it may be high and you don't know it. Now, some people will experience some symptoms like headaches or nosebleeds, sometimes shortness of breath. But generally, when you have those types of symptoms, that typically means that your blood pressure's been high for some time. Next slide. There are some common factors that put you at risk for high blood pressure, and those are outlined here on the slide. Many of those you've probably heard before, but having a poor diet, having other chronic conditions, family history, not exercising, being overweight, older age, smoking, all those types of factors can make you at higher risk for having high blood pressure. Now, I like this graphic here. This is from the American Heart Association, because it really does help us outline what the different stages of blood pressure are. So as you can see, the green line there is your normal blood pressure. And if you go to your doctor and you get your blood pressure taken, you're usually given a number of something over something. And so those two numbers are your systolic blood pressure and your diastolic blood pressure. The top one is your systolic and the bottom is your diastolic. So looking at this graphic, a normal blood pressure is one that is less than 120 on the top and less than 80 on the bottom. And then those ranges increase. And as they increase, your risk increases. So you can have elevated blood pressure that's not technically high blood pressure or hypertension. And then you have hypertension stage 1, hypertension stage 2, and then in the red line at the bottom there is hypertensive crisis, and that is a medical emergency. So if your blood pressure is higher than 180 on the top or higher than 120 on the bottom, that is a time when you need to consult a healthcare professional immediately. Now, you may be wondering why we are talking about this. Kemal did say earlier that looking at case conferences of our own patients, we see that hypertension is a very common medical problem that patients have. But what does that truly mean? Why is it important that we are discussing this today? And I think that this graphic will help illustrate that. So looking at that first number, 131 billion, that's the average amount each year that high blood pressure costs the United States in healthcare dollars. So looking at an average over a 12-year period, hypertension costs $131 billion. That is a lot of money. I don't know, Kemal, that may not be a lot of money to you, but it's a lot of money to me.
And my yearly income, right?
Yeah. And then we don't have up-to-date pandemic numbers because of everything going on with the pandemic. But in 2019, there were more than 500,000 deaths in the United States that had hypertension as either the primary cause or a contributing cause. And the exact number for that was 516,955 deaths. Just like the 131 billion, that's a lot of deaths. And it can be laid directly at the hands of hypertension. And then looking at that last number, 47% or 116 million adults in the United States have hypertension. Now, some of them are not being treated. Some haven't necessarily admitted that they have hypertension, but that's a lot of people in this country that are dealing with this condition. Let's move to the next slide. So I've painted a somewhat dismal picture in that previous slide. So I just wanted to talk about what we can do to prevent hypertension, to help avoid it, or if you already have it, what can you do to help control it? And these lifestyle factors are in no particular order, but lifestyle is extremely important when it comes to preventing or controlling high blood pressure. So first thing, if you smoke, stop smoking. And I will say that again. If you smoke, stop smoking. And I don't mean that just for high blood pressure, and we're not going to get into a lot of this today, but smoking, when I was in medical school and we were taking tests, a professor said to me one time, if smoking is listed as a possible choice for a cause for a condition, pick it, because 9 times out of 10, smoking is going to be a contributing factor to that condition. So if you're smoking, please stop smoking. Reduce your alcohol or eliminate it completely. If you are not at your ideal body weight, work on losing weight. Learn stress reduction techniques and relaxation methods to help reduce your stress. Lower your salt intake. Try to increase your fruits and vegetables in your diet. And lastly, exercise. And you don't have to have a gym. You don't need to have any elaborate workout routines. Just a pair of tennis shoes and your legs are enough to get you in a 30-minute walk every day, which will do tremendous good for your cardiovascular health.
So I think that was your
that was my last slide.
It was your last one, but I have a couple questions.
Sure.
So in terms of medication, a lot of people do have different blood pressure readings, right? So, and we do give numbers, and in some cases, someone have high readings, but it may not be high for them. It may be too high for someone else comparing to someone else. So in those cases, how do they make that decision? Like if two friends are comparing, oh, mine is like 145 versus the other person is saying mine is never over 120, and the person with 145 is freaking out. But then they read something because, you know, our people now, they are all doctors, right? So everyone goes to Google and they read and they learn and they become a doctor. So then they don't have to go to their PCPs anymore. They are very opinionated. So what can we tell them?
So I think it is important to have an open line of communication between a provider and the patient, because like you said, not everybody is the same. No two people are going to be alike. No one's going to have the same exact blood pressure as someone else. But when we look at these ranges and the cutoffs, we look at those based on data that shows what puts people at higher risk for long-term damage. We're not just talking about their blood pressure. We're talking about what type of blood pressure puts somebody at risk for doing damage to their kidneys? What about their eyes? What about their heart, their brain? All those things are affected by your blood pressure. So someone may feel fine with a blood pressure of 145/90, but they could be doing damage over time with their blood pressure staying that way for 10, 15 years. And I think that that is the conversation that's important. It's not necessarily about how you feel right now. It's about keeping you healthy for the next 15, 20, 30 years.
Now, one of the other things with the hypertension, it's the number one most frequent diagnosis with patients with COVID. And I think just you were explaining, it's usually not by itself. It doesn't like being lonely. So it does pick up other illnesses together. And it actually causes other illnesses when it's not being taken care of in a timely manner. So how are your patients dealing with this with COVID time?
So it has been somewhat of a struggle. It's getting better as things have opened up and patients are more comfortable coming to be seen at the office. But in the early part of the pandemic, it was very difficult just to try and get people to get their blood pressure checked and have their normal health care maintenance done because of fear. And unfortunately, because of the pandemic and the fact that people aren't able to go to the gym, or they're not doing the activity that they would normally do, or not going to the office and they're sitting at their desk at home for 14 hours a day, a lot of those lifestyle factors that we talked about, sedentary lifestyle, poor eating, have come into play, and that has led to weight gain. And in many instances, people's blood pressures have either gone up into the range where we feel like they need to be treated, or they will be under less control than they were previously. And so trying to encourage patients to continue to keep their health at the forefront, even during these trying times, has been a goal of myself and my colleagues at United Medical, so that we can give them the best care possible.
So this is from our little research that we had with our COVID patients, Dr. Barnett-Smith. So it's 66% of our patients who had COVID positives, they had hypertension as one of their diagnoses. So it's so common. And number two that follows this actually is morbid obesity or obesity actually. So it's one of the reasons that we actually wanted to talk about this issue today, is also with the COVID, it becomes almost more difficult. Now, you mentioned with the blood pressure, checking your blood pressure. What's the easiest way to do that? I know it sounds like a little slow question, but I'm just asking that.
Do you mean as far as
how am I going to check that?
The easiest way is to see your doctor on a regular basis, but you can also do it at home. There are blood pressure monitors that you can get at the pharmacy, and they will take accurate blood pressures, and you can keep an eye on that at home and make sure things are trending in the right direction. I generally advise patients, if they're going to do that and check their blood pressure at home, they should bring it in to their provider to have that checked, just to make sure that it is accurate, because all home devices aren't created equally. So we want to make sure that it's giving somebody an accurate reading, making sure it's not reading too low and giving them a false sense of security. But that you can check it pretty much on a daily basis if you wanted to, if you had a home monitor. But the most accurate way, we talked about the easiest way, but the most accurate way is to see your provider. And I do recommend that people come in at least once a year. If they have no medical problems and they're healthy, the best way to keep you that way is through prevention.
And so Dr. Barnett-Smith, you had mentioned about taking it at home. And so I know sometimes patients will say, well, I do take it at home, and at home it's always 120/80. But when I come in here, right, it's 150/90. So sometimes we hear that term, the white coat syndrome. So typically in cases like that, to your point, they should bring in their device so we can make sure that it's accurate. And two, usually you would take it at the beginning of the visit and then again at the end of the visit to see if they've relaxed some and some other things have transpired during that visit to see if it was unusually high at the beginning, correct?
Yes, absolutely. And one of the things that I also talk with my patients about is with white coat hypertension or stress hypertension, the question is, how often are you stressed? Because if your blood pressure is only normal when you're sitting at home with your feet up, how often can you do that? What's it doing if you're sitting in traffic or if you're at work? And because we're looking at what things are like over an average. And if your blood pressure is high on average and only in a normal range when under the best possible conditions, that still may be something that needs to be addressed.
So one of the reasons I was asking the question earlier, with the telemedicine, actually owning one of those blood pressure machines is important because then when there is a telemedicine, then at least we have some reference. So I actually didn't have one until recently, and I actually got one. It's $28. It's inexpensive. So I think even if you don't have hypertension, you should own one of those. People should be checking these more frequently, especially living at the time that we live in. It does require us to be more on telemedicine, unless there is a need for someone to be physically in the office. It's not the best. Like, I don't want my parents to be in the office if they can be taken care of from their home with telemedicine. But at the same time, to help to visit, it would be extremely useful to have daily readings, some statistics that helps the primary care providers. So that's kind of like, I was kind of leaning to that. Now, if you have a couple more minutes.
Yeah, sure.
And we don't rehearse these things, and I do repeat this sometimes because when our people are watching this, they think that we kind of talk about these. We don't. Now, hypertension is also a little bit racist, right? Like in terms of being a disease. So it's a racist disease. Like there are so many different things that's bad about hypertension, but it is on top of all that is also racist. Mm-hmm. So in terms of treating hypertension, how does that changes for you with our patient population?
Sure. So as you mentioned, there are racial disparities in hypertension, with non-Hispanic, Black patients having hypertension at a higher rate than other races. And it's also multifactorial. Is it solely race? It may be, but unlikely, because there are other factors that you have to take into consideration. So socioeconomic status, lifestyle, access to care, access to treatment. So there are several factors that are involved in that. But I think one of the things that is so important is trying to level that playing field as much as we can. And I know with our ACO, we try to identify those barriers to treatment and healthcare, and I think that is so important. I also think it's important for us as healthcare providers to meet a patient where they are, meaning that we don't get so bogged down into just treating the numbers, that we treat the patient themselves, because unfortunately, like you said, Kemal, for you're having a home blood pressure machine for $28, for some patients, that's just not doable. So there are programs. Some insurances will help cover the cost of a blood pressure monitor. So there are things that we can do to assist patients so that we're able to kind of bridge that gap, so that they're not left with more problems, less adequate health care, and then end up doing poorly.
So that's actually, that's a good point, because what we do in these case conferences, Dr. Barnett-Smith, when we are discussing the case with our nurses, we also start to process in some cases, because believe it or not, although they have insurance coverage, there are some patients they have, well, I can give you a number. There are about 20 patients who's homeless. Mm-hmm. There are more than 100 patients who have food insecurity issues. Like, it's not like the healthcare is not a cookie cutter type of approach where not everyone's need is the same. So understanding and learning about the patient is important, individual patient. So we do engage the insurance company and their case managers early on, so then they are actually working with us. And Donna actually is meeting with them. There's a different case conference on a monthly basis that they have, and that does help. And as you said, those insurances, Medicaid, they have a lot of different benefits other than just providing the coverage, including transportation, including other benefits outside of the just healthcare coverage. So, and we are trying to help our patients to reach out to those and learn about those. And actually, it's even this event is one of those efforts. And again, for you to be available on your day off is really important, and I do appreciate that. Thank you so much again. Anything you would like to add?
No, just thank you so much for having me. I always appreciate our talks and the ability to be able to get some information out there. And for those of you watching, check your blood pressure.
Will do. Thank you so much. Bye-bye. All right. Thank you, Donna.
Thank you.
All right. So Sean is back. This was a good discussion. Our next topic, Sean, you are able to hear me?
Yep, I got you.
So our next topic is our NeuraLink. So NeuraLink is something that we are going to learn more every week. So that's our kind of like project. Mm-hmm. So we are going to share some more updates with our audience. Our goal is to bring Elon Musk to this event. Sean said that he's able to do that. So yes. He was the
one call,
the quarterback of UD. He said he has some connections.
Yeah, you'd be surprised who you know out there. So yeah, obviously it would be great to have Elon hopefully on our discussion, as we are paying a lot of attention here to NeuraLink, and pretty excited about the potential benefits and what it kind of has in store for patients and both healthy and people experiencing illness for the general broad public.
Oh, well, since we started discussion, we had this question that we're asking our network, and then we have so far 52 votes. Thank you for each individual who did respond to this. It's almost, it kind of turned the other way. It used to be like 53 yes, 47 no. Now it's 48 no, 52 no, 48 yes, 52 no, right?
Yeah, there's a couple of maybes also in there, which I guess those people are on the fence, maybe waiting until we have a little bit more information.
I'm optimistic, so there are yeses.
Okay, there you go.
We'll convince them. But that means a lot of people are interested in this, but we are actually going to take a different, we're going to put a different spin on this one today. We are a healthcare organization, so we have a lot of patients, and case conferences, again, it helps us with a lot of, it gives us a lot of insight with our patients, with our needs, what our patient needs. And one of the things as we are learning more and more about NeuraLink, what we also understand is where this can be useful. And we know that Parkinson's disease and Alzheimer are the two areas that can be helpful, which we have some patient base, right, Sean?
Yep. So obviously the visuals we have here is across the entire United States. With Parkinson's on the left, it's mentioning that there's around roughly 1 million people in the US living with Parkinson's. And then on the right hand, we have almost 6 million Americans living with Alzheimer's. As you had just mentioned, within our UMACO here, we do have patients obviously falling into both of those categories. So like you said, we can definitely relate and apply some of these things here that would affect both them and, again, look at the millions of people across the entire nation.
So we know that Alzheimer medication for Medicare patients is already very expensive. We discussed this last couple of weeks. Per patient, yearly cost is about $56,000. That's a lot just for one medication, and not only what quality it's going to provide. So now going from here to our kind of like how we can actually use from the ACO standpoint.
So here we kind of have, like you said, from the UMACO standpoint with our patients. So we kind of took in some of those national averages. Like you said, in that one particular article, it said around 56,000. This one here, we have a little bit higher, it's 57.4. Obviously also taking into account other factors that would add to that cost, not necessarily just the medication, but other lifestyle changes or transportation costs that may be adding to that total number. So right here, we do have the visuals showing that Alzheimer's, like I just said, around 57,400 on average per year. And then we have Parkinson's on the left-hand side with that article citing that around $25.4 billion are spent annually across the entire nation. And as we said earlier, around 1 million people are affected by that. And so just dividing those numbers out right there, it's over $25,000, again, costing per patient on the year.
So now when we take these numbers to UMACO, we did identify some of our patients already. So unique patients is about 218. Now, this is not all patients. This is 218 when we are reviewing our regular patients day by day. That's what we identified. We didn't do a special study. I'm sure there are more patients, but just from the regular work that we are doing, that's 218. So Sean did this analysis for us to understand what the total savings.
Right. Yep. So as you see here, with our number of audits, is kind of what I was basing our numbers off of. If you want to follow the math here, so we have Parkinson's on the top. At the very top visual is 148 audits done on that, and then right below it is Alzheimer's with 138. So we have a total over 300 patients across those three groups. We also had dementia in there. But just for the number standpoint, I did do the math on the Parkinson's and Alzheimer's. So using those numbers from the previous slide on the annual medical cost averages, you see there in the chart having 148 patients with the annual cost of $25,400. And then I kind of just use the number 7 here as an example. It doesn't necessarily mean that they were diagnosed, this year and they're going to live on for another 7 future years, but, someone who could have been living with this for the past 3 years and, they go on to live another 4 years, or I was just using 7 kind of just an average number, just so we can kind of get an idea to kind of wrap our heads around the actual magnitude of what we're talking with here. So again, Parkinson's at the top, 148 with that 25,400. If you're going to have that type of medical cost over a 7-year span, that's over $26 million. And then right below is your circulating Alzheimer's, 138 patients at over $57,000 a year with medical costs. Again, spanning just on average 7 years, we're talking over 55 million. So totaling those two together, it's over $81 million in medical costs. So again, that's both, our medications, the cost of living adjustments, transportation to these appointments, all these factored in. Just with those 286 patients that we have within our UMACO, we're talking at over a 7-year span on average, over $81 million. Now, if you look at the very bottom, we did factor in, obviously this number may change, but in the early articles mentioning NeuraLink, the tentative cost to have the operation with the technology inserted, we're seeing the number around 5,000 popping up. So even just using that as an average number, 286 patients, and it only costs $5,000 on one-time cost. We're at $1,430,000. So taking that away from the total cost of the over 81 million, we are looking at potential savings of over that 7-year span of over $80 million that would have previously been allocated to, again, your medical medication costs, cost of living, and the other lifestyle costs that would go along.
This is kind of like an official invite for Elon Musk then, and then we can actually participate in their maybe research if they need any patients, because just from the initial study that we are saying that there's about 80 million savings for our patients for the 7 years, right? But there are different benefits, right? This is not just the savings, but as you prepared this for us, what we have is the quality of life for our patients, less cost for our patients, for Medicare, our government, Medicaid, our government, insurance companies, medication management needed, and other advantages. Of course, there may be some other problems, but other unknown advantages too. But this is something that is really important, so that we should be studying this more and more, and which that's what we are going to do. But I see Elon Musk actually answering a lot of stupid, messages, tweets.
Right.
This is one that he can respond that would be like a meaningful one. So we'll try to get his attention. We'll do some more work in time in the next couple weeks. So in the last week, we didn't do our book. Another thing that I don't maybe just as a teaser that we should put it out there. So we are going to also talk about humanoid. Is it humanoid?
Yeah, the humanoid robot. Actually, earlier today, there's actually a couple of releases of articles, in CNBC talking about the cost, and Tesla's Elon actually quoted that the humanoid was actually, he values it to be kind of their most important project, even over some of the new model cars that Tesla's producing. So again, that's kind of,
I'm going to get FIFO from when it's available.
there you go. But yeah, as we see, obviously a lot of insane technology advances in technology and technological advances throughout both, obviously you said our healthcare, and now with the humanoid, with Tesla and Elon kind of forefront at all of these projects.
All right. So now it's 2:49. Dr. Erkan is on call, and he didn't actually come back to me yet. Okay, let's see. So, nope, I don't have any news from him yet. My computer is slow today.
Well, to get that NeuraLink, but
Yeah, so, all right. Speaking of NeuraLink, the condition Buddy has, my puppy, is the neurological deficit. Is the same issue. Like actually, NeuraLink could help him, so the signals from the brain doesn't go to his leg on time. So, all right. So the book that we would like to discuss, we have a little bit of time. What I would like to do, Sean, let's put this out there, and we can have a little bit more time for this. We can discuss properly because this is a really important one. I want to leave people with what is execution. Execution is the discipline or the set of actions that ensure that what needs to be done gets done. So it's like the kind of like make it work. So things need getting done. Susan Anderson's, John Donnelly's, Donna Gunkel's, Richard Shaw, the Sebastian's, Anthony Anubis of this company. Those are the people from the leadership side who are getting things done. And we work with a group of people who have these disciplines, and we want to share this with others. And I do want to discuss this a little bit more in detail. So next week, we promise that we can actually do more work. So we have a lot of stuff with this book. So we can have a proper cover for this. All right, so for today, that's all we have. We are scheduled to have the Bariatric Friday in 10 minutes. Just waiting a call from Dr. Erkan. So he is on call, but as long as he's not called in, we should be good. We should be able to see you guys in 10 minutes. Otherwise, we'll see you next week. Thank you so much for joining us. Bye-bye.
All right. We're looking forward to it. Take care.